Hello everyone. Every time they ask around 35 to 40 questions in your NEET PG exam from obstetrics and gynecology. So this time also the scenario was same. They asked a major bulk of questions from obstetrics and gynecology. Today I will be discussing about NEET PG 2024 questions of obstetrics, and later I will add a video on gynecology questions. They asked about vacuum or ventouse delivery, about the flexion point. It is also known as pivot point, and it is an imaginary site on the mid-sagittal plane, which is a sagittal suture on the fetal skull. So imagine this is your anterior fontanel, this is your posterior fontanel. This flexion point is located 3 centimeter in front of the posterior fontanel and 6 centimeter posterior to the center of the anterior fontanel. This is where you apply the vacuum cup. Next, two questions were asked from magnesium sulfate topic. I am discussing about the answer of the NEET PG 2024 questions, along with that adding some more knowledge regarding the same topic. So side effects of max sulfate are warmth, flushing, nausea, vomiting, muscle weakness, and respiratory depression in extreme toxicity of magnesium sulfate. So how you will monitor for magnesium sulfate toxicity clinically? These are the normal parameters. So you will monitor for deep tendon reflex, which is mostly knee jerk. It should be normal or brisk, means normal and brisk are normal, and if it is sluggish, then it is magnesium sulfate toxicity. And respiratory rate should be more than 14 per minute. If it is less than that, then it indicates the patient is going towards magnesium sulfate toxicity. And similarly, U-output is a very important parameter. So it is more than 30 ml per hour, or in other words, it is more than 100 ml in 4 hours. Means either this or more than 100 ml per in 4 hours should be the one of the options. So if it is less than this, then it means patient is going into magnesium sulfate toxicity. So routinely, every hour or every 4 hours, we don't check for the serum magnesium levels. We assess clinically if the patient is going for magnesium sulfate toxicity or not. And only when we suspect the toxicity, then we will send the serum magnesium levels. So the normal therapeutic level of magnesium is 4 to 7 milliequivalents per liter. And these are the various regimens of magnesium sulfate which we give in preeclampsia and eclampsia. So Pritchard is intramuscular regimen, Zuspan is an IV regimen, and Sibai is also an IV regimen. DACA is a low dose IM regimen. Copper IUCD insertion. So they ask the timing for this copper T insertion. So I have put a flow chart regarding all types of insertion. This is according to the government guidelines. So you can see interval IUCD is inserted anytime 6 weeks after delivery. Or if you call it as a postpartum IUCD, it can be inserted within 48 hours. So it is less than 48 hours, or you can insert anytime after 6 weeks. So that will be the answer. And what to do if the woman becomes pregnant with copper T in situ? So always you have to rule out ectopic pregnancy. And if the patient is pregnant with copper T in situ, you counsel the woman about the benefits and risk of immediate removal of IUCD. See, removing the IUCD slightly increases the risk of abortion, while leaving it in a place can cause second trimester abortion, infection, and preterm delivery. So if strings are visible, so immediately remove if pregnancy is in first trimester. If strings are not visible, immediately you do an ultrasound. If IUD is still in place, then do not try to remove it. You continue pregnancy. Then you ensure that IUCD is removed at PPH drugs. So carboprost was asked. Actually, contraindication was, as you can see, asthma is an important contraindication for carboprost. It is always given in IM route, and the dose is 0.25 milligram or 250 microgram given every 15 minutes, and the maximum doses given are 8. Placenta accreta spectrum, also known as PAS. So, placenta accreta, here the placental villi attaches to the myometrium. Increta, it invades, that is, penetrates into the myometrium. And percreta, it penetrates the myometrium up to the uterine serosa or even into adjacent organs. Every time picture of it is asked. So this is a normal placental implantation. Here accreta where it is headed. Here increta it is invading myometrium, and percreta is total penetration up to uterine serosa and to nearby organs. This is an ultrasound picture. I want you to differentiate between placenta previa and accreta. So this is placenta previa. C is for cervix, P is for placenta. So you can see this is placenta accreta. How to differentiate? You can see here multiple placental lakes, and the very important thing is loss of hypoechoic area between the bladder and the placenta. So hypoechoic in ultrasound is black in color, hyperechoic is white. There is absence of hypoechoic zone between the myometrium and the bladder. Types of pelvis. So you have this Calvel-Molloy classification, all four types of pelvis, and just see this theoretical risk of malpresentation. So occipital posterior is most common with android and anthropoid. So question asked was phase 2 pubis delivery, which is most commonly seen in anthropoid pelvis. And when you see platypaloid, high risk of deep transverse arrest. So this is anthropoid pelvis and this is android pelvis. Twins management was asked. I just want to discuss about the delivery timing and mode of delivery. So just highlighted one is important. So DCDA twins you deliver between 37 to 38 weeks, whereas MCDA 1 week lesser than that, that is 36 to 37, and MCMA at 32 weeks. So mode of delivery, always prefer elective cesarean in MCMA twins, conjoined twins, and any obstetrical indications which mandates a cesarean section. What in other cases? Just see the presenting part. The first is cephalic, and you can try, which is discussed in next slide. The first is non-cephalic, go for cesarean section. So first twin cephalic, you can trial, give a trial of labor. When second is non-cephalic, the maneuvers used are internal podalic version and external cephalic version. So here when second in is non-cephalic or less than 1.5 kg, less than 28 weeks, which is preterm, or estimated fetal weight more than 20% of the first twin, and you should go for LSES in these conditions. Perineal tear classification. First degree is injury to perineal skin or vaginal epithelium only. Second degree, it involves the muscles. Third degree, it involves either external or internal sphincter or both. So you can see 3A is less than 50% of external anal sphincter. 3B is more than 50% of external anal sphincter, and 3C is both the sphincters are involved, external and internal. Fourth degree is same involvement of the anal sphincter complex along with the anal rectal mucosa, anal or rectal mucosa. So signs of pregnancy, this is a very favorite question. Any one of the signs are routinely asked. So Jacquemin is blue or violet colored vagina. Goodle is softening of cervical lips. Osiander is pulsation detected in the vaginal fornices. Hegar is softening of the isthmus leading to approximation of abdominal and vaginal fingers below the body of the uterus. Palmer sign is uterine contractions which may be palpable. Tubal ligation. So here the question asked is the site. So isthmus is the narrowest part of the fallopian tube. Remember, tubal ligation is done at the level of isthmus. Whereas fertilization occurs in the widest part of the fallopian tube, which is ampulla. Never get confused with these 2 points. And you should remember different techniques of tubal ligation. And we use commonly modified polymerase technique. Others are Parkland, Uchida, Irving, Medlana, and Croena. Breach, two questions were asked regarding delivery of after coming head and the forceps used. So two techniques are modified Mauritius smelly wheat and burn Marshall. So how to differentiate between this? See this picture. Here you place the left hand inside the vagina and you give malar flexion here, and right hand at the back of the fetus giving a shoulder traction. So just remember this picture. Whereas in burn Marshall, you make a wide arc of circle over the maternal abdomen. So when this kind of picture is given, just go directly click burn Marshall technique. So Piper's forceps, it is almost you will get confused with the outlet forceps, but here remember there is absent pelvic curve. So contraindications of external cephalic version, absolute contraindications are anything which contraindicates to labor and vaginal birth. Examples like placenta previa and previous classical cesarean birth. Obviously, you should go for a cesarean section only. So you don't want to even try for external cephalic version, because here our aim is to give a trial of labor, that is vaginal delivery. In these conditions, we can't try any vaginal delivery. So obviously, then ECV is contraindicated in these conditions. Relative contraindications are non-reassuring fetal monitoring test results, like your non-reassuring NSTs, placental abruption, which is again an emergency, rupture membranes where you don't have enough LICA, same severe oligohydramnios, you don't have enough LICA, significant fetal or uterine anomaly like hydrocephalus septate uterus. So first trimester MTP, the medical method was asked. You give a mifepristone followed by misoprostol. Herpes simplex virus infection, previous LSCS women. Obviously, you should go for an elective LSCS. And two questions were asked regarding anticoagulation during pregnancy. I just want you to remember this concept. Warfarin is a teratogenic drug. So, any teratogenic drug is contraindicated in first trimester. Less than 12 weeks, you give heparin. Ideal is low molecular weight heparin. So, between 12 to 36 weeks, you can switch over to warfarin. After 36 weeks till delivery, then you should again switch over to heparin, and most commonly preferred is low molecular weight heparin. Thank you. I will add a video soon on gynecology questions. Please post your suggestions in the comment section. And for more knowledge regarding your PG preparation, please follow my Instagram page, Experts Obs Gynae, and also my YouTube channel, Begin OG Lab. All the very best. Thank you.